Hello, hello, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about chapter 38, your vasodilators. Vasodilators can be produced with a variety of drugs. What sets vasodilators apart from other drugs that cause vasodilation is their mechanism of action. They act directly on the smooth muscles in the arterioles and veins to produce vessel relaxation. Two agents, hydralazine and minoxidil, are introduced here. A third, sodium nitroprusside, is used in emergency situations within inpatient settings. This drug is discussed in Unit 21 on drug therapy in acute care. In approaching the vasodilators, we begin by considering concepts that apply to vasodilators as a group. After that, we discussed the pharmacology of individual agents. So, basic concepts in vasodilator pharmacology. Selectivity of vasodilatory effects. Vasodilators differ from one another with respect to the types of blood vessels they affect. Both hydralazine and minoxidil produce selective dilation of arterioles. Nitroprusside dilates both arterioles and veins. The selectivity of a vasodilator determines its hemodynamic effects. For example, drugs that dilate resistance vessels, your arterioles, can cause a decrease in cardiac afterload, the force the heart works against to pump blood. By decreasing the afterload, arteriolar dilators reduce cardiac work while causing cardiac output and tissue perfusion to increase. In contrast, drugs that dilate capacity vessels, your veins, reduce the force with which blood is returned to the heart, which reduces ventricular filling. This reduction in filling decreases cardiac preload, the degree of stretch of the ventricular muscle before its contraction, which in turn decreases the force of ventricular contraction. Therefore, by decreasing the preload, venous dilators cause a decrease in cardiac work, along with a decrease in cardiac output and tissue perfusion. Because hemodynamics responses to dilation of arterioles and veins differ, the selectivity of a vasodilator is a major determinant of its effects, both therapeutic and undesired. Undesired effects related to selective dilation of arterioles and veins are discussed later. Therapeutic implications of selective dilation are discussed in Chapter 39, 40, and 43. So, the overview of therapeutic use. The vasodilators as a group have a broad spectrum of use. Principal indications are essential hypertension, hypertensive crisis, angina pectoris, heart failure, and myocardial infarction. The specific applications of any particular agent are determined by its pharmacologic profile. Important facets of that profile are the route of administration, site of vasodilation, arterioles, veins, or both, and the intensity and duration of its effects. So, adverse effects related to vasodilation. Your postural hypotension. Postural orthostatic hypotension is defined as a fall in blood pressure brought on by moving from a spine or seated position to an upright position. The underlying cause is the relaxation of smooth muscles in the veins. Because of venous relaxation, gravity causes blood to pool in veins, thereby decreasing venous return to the heart. Reduced venous return causes a decrease in cardiac output and a corresponding decrease in blood pressure. Hypotension from venous dilation is minimal in recumbent subjects because when they are lying down, the effect of gravity on venous return is small. So patient education, the risk for hypertension with a vasodilator. Vasodilators place patients at increased risk for falls. Patients receiving vasodilators should be informed about the symptoms of hypotension, lightheadedness, dizziness, and be advised to sit or lie down if these occur. Failure to follow this advice may result in fainting. Patients should also be taught that they can minimize hypotension by avoiding abrupt transitions from a spine or seated position to an upright position. So the pharmacology of an individual vasodilator, such as hydralazine, its cardiovascular effects. Hydralazine causes selective dilation of arterioles. The drug has little or no effect on veins. Arteriolar dilation results from the direct action on vascular smooth muscle. The exact mechanism is unknown. In response to arterial dilation, peripheral resistance and arterial blood pressure fall. In addition, heart rate and myocardial contractility increases, largely by reflex mechanism. Because hydralazine acts selectively on arterioles, postural hypotension is minimal. Its pharmacokinetics, absorption, and time course of action. Hydralazine is readily absorbed after an oral administration. Effects begin within 45 minutes and persist for up to 6 hours. With parenteral administration, effects begin much faster, within 10 minutes, and last about 2 to 4 hours. Metabolism. Hydralazine is inactivated by the metabolic process known as acetylation. The ability to acetylate drugs is genetically determined. Some people are rapid acetylators, some are slow acetylators. The distinction between rapid and slow acetylators can be clinically significant because individuals who acetylate hydralazine slowly are likely to have higher blood levels of the drug, which can result in excessive vasodilation and other undesired effects. To avoid hydralazine accumulation, dosage should be reduced in slow acetylators. Its therapeutic use. Its big one, essential hypertension. Oral hydralazine can be used to lower blood pressure in patients with essential hypertension. The regimen almost always includes a beta blocker and may include a diuretic as well. Although commonly employed in the past, hydralazine has been largely replaced by newer antihypertensive agents, which we'll discuss more in Chapter 39. The following table here shows vasodilator preparations, the dosage, and administration. It's a good spot to hit pause if you're unfamiliar with some of the medicines. The next is heart failure. As discussed in Chapter 40, hydralazine, usually in combination with isorzabide, can be used in short term to reduce afterload in patients with heart failure. With prolonged therapy, tolerance to hydralazine may develop. It does cause potential adverse effects. The big one, reflex tachycardia. By lowering arterial blood pressure, hydralazine can trigger reflex stimulation of the heart, thereby causing cardiac work and myocardial oxygen demand to increase. Because hydralazine-induced reflex tachycardia is frequently severe, the drug is usually combined with a beta blocker. Its increased blood volume. Hydralazine-induced hypotension can cause sodium and water retention and corresponding increase in blood volume. A diuretic can prevent volume expansion. Systemic lupus, erythematosus-like syndrome. Hydralazine can cause an acute rheumatoid syndrome that closely resembles systemic lupus. Symptoms include muscle pain, joint pain, fever, nephritis, pericarditis, and the presence of anti-nuclear antibodies. The syndrome occurs most frequently in slow acetylators and is rare when dosage is kept below 200 milligrams per day. If there is a systemic lupus type reaction that occurs, hydralazine should be discontinued. Symptoms are usually reversible but can take up to 6 months. In some cases, rheumatoid symptoms can persist for years. Other adverse effects. Common responses are a headache, dizziness, weakness, and fatigue. These reactions are related to hydralazine-induced hypotension, most likely. Other drug interactions. Hydralazine can be combined with a beta blocker to protect against tachycardia, which is a reflex, and with a diuretic to prevent the sodium and water retention, and the potential to expansion of blood volume. Drugs that lower blood pressure will intensify hypotension responses to hydralazine. Accordingly, if hydralazine is used with other antihypertensive agents, care is needed to avoid excessive hypotension. In the treatment of heart failure, hydralazine is usually combined with isorzabide, a drug that will help dilate the veins. That brings us to minoxidil. Minoxidil produces more intense vasodilation than hydralazine, but also causes more severe adverse reactions. Because it is both a very effective and very dangerous, minoxidil is reserved for patients who have severe hypertension that is unresponsive to other medications. So, its effects on the cardiovascular system. Similar to hydralazine, minoxidil produces selective dilation of arterioles. Little or no venous dilation occurs. Arteriolar dilation decreases peripheral resistance and arterial blood pressure. In response, reflex mechanisms increase the heart rate and myocardial contractility. Both responses can increase again that cardiac oxygen demand and can thereby exacerbate angina. Vasodilation results from the direct action on the vascular smooth muscle. To relax vascular smooth muscle, minoxidil must first be metabolized to minoxidil sulfate. This metabolite then causes potassium channels in the vascular smooth muscle to open up. The resultant efflux of potassium hyperpolarizes vascular smooth muscle cells, thereby reducing their ability to contract. Its pharmacokinetics. Minoxidil is rapidly and completely absorbed after oral administration. Vasodilation is maximal within 2 to 3 hours and then gradually declines. Residual effects may persist for 2 days or more. Minoxidil is extensively metabolized. Metabolites and the parent drug are eliminated in the urine, and the drug's half-life is about 4.2 hours. Its therapeutic use. The only cardiovascular indication for minoxidil is again severe hypertension. Because of its serious adverse effects, minoxidil is reserved for patients who have not responded to safer drugs. To minimize adverse responses, again, reflex tachycardia, expansion of blood volume, and pericardial effusions, minoxidil should be used with a beta blocker plus intensive diuretic therapy. Your topical minoxidil, or Rogaine, is used to promote hair growth in balding men and women, and we'll discuss that more in chapter 85. Adverse effects. Again, the big one, reflex tachycardia. Your blood pressure reduction triggers reflex tachycardia, a serious side effect that can minimize by co-treatment when given with a beta blocker. Sodium and water retention. Fluid retention is both common and serious. Volume expansion may be so severe as to cause cardiac decompensation. Management of fluid retention requires a loop diuretic such as Lasix, used alone or in combination with a thiazide diuretic. If diuretics are inadequate, dialysis must be employed, or minoxidil must be removed. Hypertrichosis. About 80% of patients taking minoxidil for 4 weeks or more start to develop hypertrichosis, which is excessive growth of hair. Hair growth begins on the face and then later develops on the arms, legs, and back. Hypertrichosis appears to result from the proliferation of epithelial cells at the base of the hair follicles. Vasodilation may also be involved. Hairiness is a cosmetic problem that can be controlled by shaving or using a depilatory. However, many patients find hypertrichosis both unmanageable and intolerable, and therefore refuse to continue treatment. Minoxidil comes with a big black box warning. Minoxidil can cause pericardial effusions, occasionally progressing to a tamponade, which may exacerbate angina. Other adverse effects. Minoxidil may cause headache, fatigue, nausea, breast tenderness, glucose intolerance, thrombocytopenia, and skin reactions, such as Stevens-Johnson syndrome. In addition, the drug has caused hemorrhagic cardiac lesions in experimental animals. So there is this section here that I would like you to pause that before we finish this chapter here, and that's on the patient-centered care across the lifespan, which are your vasodilators. Again, this is already the end of those chapters, so I thank you for listening, and I hope you have a wonderful rest of your day. Thank you, and goodbye.